Good morning, everyone. Thank you for joining us for another APSET Insight webinar. My name is Jackie, and I'm one of the nurse educators here at Insight. And before we begin, I would like to acknowledge the traditional owners and then the custodians of the land on which we are presenting on today. I would like to also pay my respect to elders past, present, and emerging. I would also like to extend that respect to any Aboriginal and Torres Strait Islanders, people who might be joining us on the webinar today. So as I'm sure you all know that from our program, we have Debbie Rigby today joining us to talk about QScript and benzodiazepine and Z drugs. So Debbie is an advanced practice pharmacist who has a special interest in prescribing, medication reviews, and medicines information, amongst many other things. So she has worked in many roles across the communities, hospitals, and policy and advocacy. So she's currently providing a home medication review service and educations to health professionals. We're very lucky that Debbie can fit us in today. We also have Tanya Bang with us today and from QScript, who will be available to help answer any QScript related questions. So thank you, Tanya, for joining us today. Before we start, just a little bit of housekeeping. So if you do have any questions, please pop down in the chat box and we will try to get them answered at the end of the session. So that is for me, and I'll hand over to Debbie.
Okay, thank you. I too would like to acknowledge the traditional custodians of land on which we are speaking and pay my respects to elders past, present and emerging. And thank you also to Insight for asking me to speak today. As a pharmacist, I don't work in community pharmacy anymore, but I do see work across the whole spectrum of healthcare. And I think it's a really interesting time on top of COVID and the mental health issues that it has brought to talk about drugs of dependence, and in particular benzodiazepines and so-called Z drugs. And one of the things they are in popular language, and these are just some of the lay terms and slang that are used around benzo. I'll probably call them benzos. I think words that have 4 syllables are way too many. So benzos, but there's sort of slang that's around, and we've all heard of roofies and tranks, meaning tranquilizers, moggies, Mogadon, Blue V, which is Valium, they little blue pills, Rowies, and so on. So I think that's probably part of the problem, that the average person is aware of benzodiazepines, and in particular, perhaps, diazepam, Valium, as well as, across the whole spectrum of them. So, their awareness of what they can do potentially. And I think one of the messages I want to get out of this talk today is that there is appropriate use. They do have a place in therapy, but they certainly have misuse, abuse, and dependence problems. And I love art, so I try to find paintings that also depict what I'm talking about. And this is the famous Scream on the left-hand side. Edward Monk is the artist. And it's often used to describe pain, a person in pain. But it was actually, it was sort of meant or interpreted as a self-portrait where he was going through a lot of mental health issues, psychotic depression. And you can see, I think, they feel the emotion in that painting around the pain, the anxiety, the depression, the psychosis that he may have been feeling. And the one on the right-hand side is perhaps lesser known. It's called Anxiety by the same artist, and in fact painted in the same place. And again, I think you can perceive the anxiety, the almost faceless paintings of the people and in particular, the lady at the front, the anxiety that she may be feeling. So whilst you may not have experienced that yourself, we've certainly had experience with our patients that are feeling it. So what I wanted to go through today is a little bit around the pharmacology of benzos, describe where they are appropriate, the rational use of benzodiazepines and Z drugs, talk in a little bit more depth around the adverse effects and the risk of harm associated with them, and then finish off with how to deprescribe, which is, as we all know, not an easy thing, but there are a lot of resources and tools that we can use for that. So this was a bit of a timeline that I spent hours developing this slide. And I think it's interesting that, before benzos, we had barbiturates. So when I first started in pharmacy, barbiturates were probably one of the number one drugs that we dispensed, Nembutal, for example. And then it was only in the 1950s that this Austrian scientist identified and developed benzodiazepines. And the first one that came to market was in 1959, called iazopoxide or Librium. And more recently, if you saw the Queen's Gambit, that show a series around chess player, where she was given these little pills, blue and green pills in the orphanage to calm the children down. So it was, that's exactly what they looked like. And then in 1963, diazepam, Valium, came to market. And within the next decade, Librium and diazepam became the number one prescribed medicines worldwide. And then only a few years later, there was this first warnings around the potential harm associated with long-term chronic use of benzodiazepines. And 1981, Alprazolam and Xanax was not actually marketed as Xanax anymore because it was taken up schedule to be a scheduled drug, a Schedule 8 drug or controlled drug in 2014, I think it was, and Xanax, that as the brand went off the market then. And then more recently in this decade, we've seen the emergence of the Z drugs, so-called Z drugs, so Zolpidem and Zolpiclone. So it's interesting that history, when benzodiazepines first came to market, as I said, they sort of replaced barbiturates, and they were marketed as non-addictive, the early days saying these wonder drugs, non-addictive, and they work so well, sort of thing. And I think some of the early ads really help understand that, and the marketing that was there. And the one talking about Librium, most accessible, making the patient more accessible and communicative. And the one on the right-hand side talking about alcohol withdrawal, and that was an ad in 1963. And then with diazepam coming to market, these old ads, Mother's Little Helper, sweet, refreshing Valium, when denial is the best alternative. Fortunately, we've moved on from that philosophy, but there. And I think the other ad itself really is quite dramatic. I find it quite emotional, talking about reduced tension, psychic tension, the role of Valium there. So we do have a lot of drugs of dependence. This was the National Drugs Strategy Household Survey, came out just recently, and just identifying the different drugs. They're all drugs. Smoking, 14% of the Australian population smoking. Recent use, meaning in the last week, 3/4 of Australians. I couldn't find a little icon for marijuana. I know that's maple leaf, but marijuana and now medicinal cannabis, over 10% of the population. But looking here, tranquilizers, that's the term that was, when I went through uni, we talked about minor and major tranquilizers, and benzos and barbiturates were considered minor tranquilizers, and major tranquilizers were antipsychotics. But, nearly 2% of the population had used them, and opioids, 2.7%. So But the issue is many people use every single one of those, don't they? And I think that's where a lot of the dependence and harm is associated with it. So over 7 million PBS subsidised prescriptions are dispensed every year across all the benzodiazepines. And interesting, there's been lots of research and studies at NDARC and in particular UniSA doing some analysis of PBS scripts. The quantity prescribed on each script is increasing over the last 20 years. It varies, and it's sometimes, I think, illogical, the quantity that's in some of these medicines on the PBS. But as I said at the start, reinforcing that benzos may be clinically indicated for a range of conditions, for different anxiety disorders, insomnia, epilepsy, alcohol and other drug withdrawal treatment, but they're not considered first-line therapy for any of those conditions now. So just looking some stats at benzo use in Australia, this was out of the UniSA people, and they did a 10% sampling of PBS data and showing across all the different types of benzodiazepines. Diazepam was the most prescribed and dispensed, followed by temazepam, fortunately declining, and it'll be interesting to see more recent data around Alprazolam when it was made Schedule 8 or a controlled drug in 2014. But they did find 1.5% of the Australian population had been dispensed a benzo in recent times. And then looking at that, at the actual use of benzos, 1 in 10 were considered inappropriate, potentially inappropriate. And their definition of that was having 3 or more dispensings in the previous 90 days. Because as we know, it's indicated for short-term use, but many people will, keep using it for years, if not decades. And within that sample size, 45 per 1,000 population had initiated benzodiazepines in 2017. Slightly more female. Fortunately, I think 75%, 3/4 were aged less than 65 years, because we know that benzos have a greater risk in older people for falls, fractures, and so on. And I think, so that's good. Majority, most of my work is in aged care, so I still do see a lot of people who've been on benzos for decades and started on it, especially on admission to aged care facilities. But it'll be interesting to see the impact of the Royal Commission into aged care and their focus on inappropriate psychotropic drug use, how that translates over the next couple of years. But I think alarmingly, nearly 20% of benzo scripts were co-prescribed with opioids, and I'll talk a little bit more about that. And this is NDARC data. It was just released, but it was 2019 data showing nearly 2,000 deaths due to drugs, and 61% had opioids, were implicated from opioids. But benzodiazepines were the second most common class of drug associated with drug-induced deaths. And it is, I hope they delve down into this. So I've got anti-epileptics, sedative, hypnotic and anti-Parkinson's drugs lumped together, but 51% of drug-related deaths were, they were implicated with it. And again, the shift in use of the gabapentinoids, pregabalin, Lyrica, and gabapentin, Neurontin, is interesting to follow. But benzos were involved in 55% of opioid-induced deaths. So that combination is seriously something that we need to look at. And worldwide, the US FDA has just late last year put out a box warning around benzodiazepines to address the serious risks of abuse, addiction, physical dependence and withdrawal reactions, and gave this guidance around the risks and how we should be discussing it with patients. So assessing the patient's risk of abuse, misuse and addiction, and we all know the tools that we can do for that. There's caution around co-prescribing with opioids, the lowest possible dose for the shortest duration, which is fine to say, hard to do in practice, considering alternate therapies and in particular non-drug therapies. But again, that's hard to do because patients want a pill for every ill, and to do those lifestyle changes and so on can be challenging. And do we have the services, as in access to psychologists and psychiatrists? There certainly is a growing access there, but it can be problematic in some areas. And then this need to follow up with patients who are dispensed benzodiazepines frequently, and certainly QScript will, and the real-time monitoring around Australia will have and is already having an impact on that. So as a pharmacist, I always go back to the pharmacology of drugs and thinking how they work. And essentially this little diagram showing up here, you swallow the drug, or can be IV, but mostly oral. And they actually, the little white triangles are showing how it binds to the GABA-A receptors. There's different GABA receptors, but it binds to GABA-A receptors and enhances the effects of a GABA, which has a inhibitory or decreases the reactivity in these postsynaptic neurons to decrease the anxiety and have these effects. And also the amygdala in the brain, which is anxiogenic, so causing anxiety, it also has this inhibitory effect there. Barbiturates, so it's not a direct agonist, whereas barbiturates were a direct agonist on the GABA-B receptors. So it has a different mode of action, but essentially the same outcome there. We've got a lot of benzos. Some you don't see used very much. Some are like clobazam, very specialised areas in kids' paediatric epilepsy. But the main ones we'd see Alprazolam. I should take out Xanax. The brand name is no longer there. So they're sort of grouped into their duration of action, so the half-life of the drugs. So Alprazolam, oxazepam and temazepam are short-acting, so acting 6 to 12 hours, and hence quite often used, especially temazepam and oxazepam, used as hypnotics, so helping with sleep. But Alprazolam, which I really hate, it's a horrible drug. It's very short-acting, works quickly, which is why patients like it. But it has, people can act, because it is so short acting, it binds very strongly to the receptors, GABA receptors, and therefore is quite potent in its activity, but it's short acting. So people, for example, if they're dosed twice daily, they can actually go through withdrawal in that period because it's works quickly, it's in their body, but it's also out of their body quickly. So they can experience withdrawal symptoms, which they can interpret as increased anxiety and therefore take another one. So people might be on 3 times a day, but as we all know, and especially because of the quantity that's dispensed on the PBS, people will self-medicate and take it more often. And hence why it has become a drug of misuse as well as abuse, and made a Schedule A drug. Then we've got medium-acting ones like lorazepam, Ativan, and the longer-acting ones, nitrazepam in particular. You don't see a lot of Mogadon prescribed these days because it is so long-acting. It does have that, when it's being used as a hypnotic for a sleeping tablet, has that hangover effect because of its long half-life, and it's going to stick around in the body. Typically, we say 5 half-lives, so if it's got a half-life of 24 hours, there's still going to be some residue in the body 5 days later. And if you're dosing daily, every night, that's when you start to get that accumulation. And it's also around their metabolism, how there's phase 1 and phase 2 metabolism, and diazepam is oxidized, so through the cytochrome P450 enzymes, which are in your liver and throughout the body. And I always say diazepam has a half-life of around 20 hours in a 20-year-old and around about 80 hours in an 80-year-old. Because of the decline in the CYP3A4 enzymes in the body, but also the increased sensitivity that the aging brain has to CNS drugs like benzos. So, half-life of 80 hours, and if you're dosing it 3 times a day, that accumulation, and they're lipophilic drugs, so they're accumulated in the fat in the body, and hence can cause the problems that we all know about. It's also interesting to look at these comparative oral doses. And again, I'll pick on Alprazolam because I hate it. This is out of therapeutic guidelines and looking at the dose equivalents compared to 5 milligrams of diazepam. So Alprazolam comes in doses of 0.5 milligram, 1 milligram, 2 milligrams. And I see patients on 2 milligrams of Alprazolam maybe 2-3 times a day. But 2 milligrams is equivalent to 20 milligrams of diazepam, of Valium. And that surprises prescribers, GPs at times, as certainly patients. And they say, I talked to a patient and they might have a patient who was on Alprazolam 2 milligrams TDS, and she was topping up and taking extras. And when you work that out, that's 60 milligrams of Valium. And she said, oh my God, I wouldn't take that. She also had some PRN Valium. And, that is astounding to patients as well as prescribers and pharmacists and all of you. So I find this conversion table very useful when you see people that are on multiple benzos. They might be on oxazepam, Seropax, temazepam at night, some Alprazolam for their anxiety disorders. And when you work out, they're a little bit like working out the oral morphine equivalents for opioids, you work out exactly how much diazepam equivalents they're taking, and that can be quite astounding and scary at times. So as I said, we've in the recent years or decade or so, we've had Z drugs, zolpidem and zopiclone, so Stilnox and Imovane. Then, non-benzodiazepines. They're structurally unrelated to benzos, but they really act in much the same way. They do have a short half-life. They're typically used for as sleeping tablets rather than anti-anxiety tablets. They do work quickly. And you literally, I tell patients, don't take like temazepam. You'll sometimes say, take it, you're deciding to go to bed because they take around about half an hour to work. Whereas with Z drugs, I'll say to patients, take them as you're going to bed. Clean your teeth, take your zolpidem, and go to bed because they can work very quickly. I've had people that, within five minutes have fallen asleep in the lounge chair or whatever because they've taken it like that. So they work quickly. They've got their whole, I'm not going to touch on really their side effects and adverse effects, whole other raft of parasomnias, aberrant behaviours, sleepwalking, sleep talking, sleep drinking, sleep sex, sleep smoking, all sleep driving, all the sort of aberrant behaviours associated with Z drugs. But they, as I said, they do have a place, and these are where considered clinically appropriate for as an anxiolytic. So with generalised anxiety disorder, social anxiety disorder, PTSD, OCD, various panic disorders and phobias, as an anticonvulsant, a muscle relaxant, especially around, I know it's used acutely for back pain, for example, but also used chronically for the muscle spasticity associated with multiple sclerosis, as a sleeping tablet, pre-op midazolam in particular, pre-op anesthesia and alcohol withdrawal. But as I said, they're not first-line therapy for any of those conditions and should be used for the shortest period of time at the lowest dose. So all the textbooks say, only use 2 to 4 weeks because you start to develop tolerance in that time. it's hard to convince patients of that, as I'm sure you're aware, that, they say, oh, I can't go to sleep without my temazepam. It works. If I don't take it, I don't get to sleep, sort of thing. So I think right from the start, helping people, I know when I teach pharmacists, they should be saying to patients, especially on the first prescription, do you have a plan? Helping them understand that it's only short-term use and that deprescribing or stopping drugs should be part and discussed, especially when we're talking about psychotropic drugs and opioids and other analgesics when the drug is first commenced, saying, and one of my try to drum it out of pharmacists and in particular pharmacy students, do not say you're going to take this drug for the rest of your life, whether you're talking about a statin or a blood pressure drug, and in particular psychotropic medicines. We need to review them regularly, and getting patients back can be challenging. Or the sort of non-drug, I'm sure you're all aware of the sleep hygiene non-drug strategies and interventions for insomnia, anxiety, SSRIs and SNRI antidepressants are first-line therapy for anxiety, and CBT as a non-drug intervention. When we're talking about for seizures, excuse me, yes, they do have a place, usually as an adjunct when other anti-epileptics are not tolerated, and certainly have a place in alcohol withdrawal, but limited to 7 days. As I said, my main practice is in aged care and doing these home medicine reviews to people, older people in the community, and sleep problems is probably sleep and pain is what patients, when I ask them, what are your concerns? Sleep and pain would be the number one things. So as we age, our sleep patterns do change. Over 50% of older people have some form of sleep disturbance, lower nighttime sleep quality, and these sort of age-related changes that do occur, as well as the accumulation of chronic diseases and in particular dementia, can have an impact on your circadian rhythms and sleep quality. This was a study again by the South Australian people looking at across 6 aged care facilities and mean age, older population, majority women, because men have or women have a longer life expectancy. But look at this, a quarter of them were taking regular benzos, nearly a third on PRN benzos, and a significant proportion were taking 2 or 1 or more benzos. So it really is about balancing this risks and benefits. And I tried to show the risks, the harm is much, much greater than the benefits. And this surprises patients and prescribers at times. And there's different figures, but I just found it in this journal article. The sleep latency is the time to get to sleep. So benzodiazepines, they reduce that time by 4 minutes. It's not a lot. People say, oh, I can't get to sleep, I'm awake for hours, sort of thing. But taking a benzo like temazepam reduces that by less than 5 minutes. Increases the sleep duration. And again, this, I should have put the range. It really varied from like 30 minutes to 60 minutes. It's increased sleep duration. But the harms associated, so it reduces your deep sleep, the stage 3 sleep and REM sleep, which is necessary for your learning and consolidation of memory and knowledge, increases daytime drowsiness and dizziness, and therefore increases the risk of falls and cognitive impairment, that sort of brain fog, drowsiness, and people that are taking it, on prescription, let alone from misuse or abuse, and this increased risk of overdose, especially when taken with opioids. So we've got a whole range, lots and lots of them. as I'm sure you're aware, more aware than me, taking it in combination with alcohol increases the risk of harm. And I really just want to touch on and emphasise the risk of concomitant use with opioids. So this just showing the twofold increased risk of admission or presentation to ED and inpatient admission for opioid use with concurrent use. And if we actually address this, it would reduce this admission for opioid overdose by 15%. If we look at that was US data. If we look at Australian data, the South Australian people love their data mining, and this was just looking at the concomitant use of benzos and opioids in Australia, and found that 1 in 8 people dispensed opioids were also dispensed benzos in 2017. And you can see with looking at I can't see, it's in the way, temazepam and diazepam, I think, yeah. The concomitant use there, methadone and diazepam implicated in a lot of the coroner's reports, the concomitant use, nearly 50% up there. So fairly profound concomitant use there. And further looking, and this is just looking at quarters, 3 months periods. Yes, appropriately, I guess, we're saying it should be used short term, but look at the long-term use. More people were dispensed opioids than benzos in the short term, but in the longer term, benzos were dispensed for a longer duration. You can see how the orange becomes greater than the blue for opioids. And looking at many years later, that concomitant use there. So Z drugs and opioids have similar potential for harm, and this the risk of overdose associated with them as well. I'm sure you're all aware of the adverse effects associated with benzodiazepines, and I really just highlighted the falls, the sedation, the cognition, cognitive impairment associated with it, and that all of these effects are more common in older people. The sedation, impaired motor skills, which people may not be aware of, shouldn't be driving, impaired concentration, paradoxical effects, that hyper-excitability, anxiety, hyper-anxiety state for some people, rebound effects. So if you don't take it, with temazepam, I always tell people, see if you can take it or not take it more days of the week than taking it. So yes, you might take temazepam, for example, for sleep 3 nights a week, and not take it 4 nights a week, and try and just get that balance, trying to avoid these rebound effects, to avoid the potential for tolerance. Overdose is not as, certainly that, and that's where barbiturate, overdose was, mostly lethal back last century. But overdose simply with benzos is somewhat challenging, but as we all know, the many people who are abusing these drugs will take a whole cocktail. And if you look at the cocktail that Michael Jackson was taking or Heath Ledger was taking, it's the combinations, in combination with alcohol, which is a drug. And just this week, I saw the coroner's report from Michael Gudinski, the mushroom records guy. And from memory, he was taking, they found in his blood cocaine, ethanol, oxycodone, codeine, tramadol, diazepam, temazepam, nitrazepam. And, it's just this whole, and paracetamol, huge dose of paracetamol. This cocktail which has this potential of death in overdose there. So treatment, this overdose symptoms, respiratory depression, usually treatment is supportive. The use of, I don't see it, you might, the use of flumazenol is as a antidote, competitive antagonist is rarely used these days, but it might be in specialised areas. Just again, touching on dementia, I know I'm biased to where the patients I see, and again, looking at the impact of the Royal Commission into aged care and psychotropic drug use, hopefully we will see a drop in the inappropriate use of benzos as a chemical restraint or resistive practice as a result of the Royal Commission. But there's actually very little evidence in dementia that it improves sleep quality, because it doesn't have that impact on the circadian rhythm, which is impacted with dementia. There is a role perhaps more appropriately for melatonin, which has can help with that circadian rhythm there. So dependence, it's probably what you guys see more than me. It is an issue, and this ongoing use and dependence on benzos, and in particular in combination with other drugs, and especially opioids, is a challenge that we're facing. And especially high doses, this risk of dependence is quite high. The risk increases both with the dose and the duration of treatment. About a third of patients who've been prescribed benzos long-term may have difficulty in reducing or stopping them. So don't underestimate, either from the patient or from a health professional point of view, how challenging it is for people to reduce or deprescribe these drugs. Patients on long-term prescribed benzos are likely to be dependent, even if the dose is stable. So I had this discussion with GPs quite often. They've been on it, they're on Seropax, 15 milligrams TDS for a long time. And that the feedback I say here is, they're not dependent, they're not escalating the dose, they just need it. And then, look at their history of falls, talk to the patient if they don't have dementia around their, fogginess, their inability to concentrate, to read, to do whatever is a challenge. People with current or previous alcohol and drug problems are at an increased risk of developing dependence from benzos. The Z drugs have similar effects. And this severe dependence, especially on people who are polydrug dependent. So the NPS medicine-wise had a really good article a couple of years ago, I think it was 2017, around benzo dependence, and it's still up on their website. And they classified benzo dependence across these three different types, looking at low dose or therapeutic dose dependence, where it's used, initiated for insomnia or anxiety, and the doses that are prescribed and taken are within what we would consider the appropriate therapeutic use. But there is this dose escalation over time because of the tolerance. The next group is people prescribed high dose dependence, or high dose benzos. And they start to need, as you know, how tolerance develops and need higher and higher doses, and this escalation of doses far in excess of what's considered the appropriate therapeutic dose. And then the so-called recreational use, I hate the word recreational drugs, but that high dose dependence is there too. And these are the sort of behaviours to look out for that they describe: the need to carry their tablets around with them, the tendency to take an extra dose in anticipation of an event like in social anxiety, coming back to get prescriptions before they've run out. All these issues, I'll skip through them because I'm running out of time. The so-called lost prescriptions. Taking hypnotic sleeping tablets during the day, those sort of issues. And these drug-seeking behaviours, and they classified them into indicating risk, but also these behaviours here around highly predictive of problematic use. And the substance use disorder, DSM criteria across these 4 criteria of having 2 or more of the 11 symptoms or criteria defined substance use disorder. And I really like this little diagram. It just sort of identifies how people starting on benzos, and they may get a clinical benefit from the drugs if they're used appropriately. Should be short-term use, that 2 to 4 weeks, and they stopped or taper the dose and start experiencing perhaps withdrawal effects, especially if it's stopped abruptly, and then that trajectory that can occur there. Thinking about these withdrawal symptoms, the half-life of the drug is important to consider. So short-acting ones, the onset of withdrawal symptoms are even after 1 to 2 days, whereas longer-acting benzos like diazepam, the onset of withdrawal symptoms would be greater. We all know, do not cease benzos abruptly. I've seen some patients who've decided, I want to get off these, and they stop abruptly and not surprisingly experience withdrawal symptoms, which you're all aware of. There's different recommendations around how to reduce off benzos. Reducing, I think, for many, many people, they've been on it for a long time. Therefore they need to take their time to get off it, because there's nothing like experiencing withdrawal symptoms to start the person back taking those benzos again. Allow the patient sometimes to stabilise between each reduction, so doing it slower is probably better for many people, depending on their clinical and their own preferences, and that may vary significantly. I won't go through the withdrawal symptoms in any real detail, but the NPS website, they sort of put them into these 3 categories: the physical, psychological, and the sensory ones. And when I'm talking about the GPs I work with, they want me to have a conversation, because when I'm doing home medicine reviews, I've got the luxury of time. I'm in the person's home, talking to them for an hour or more, and going through, so helping people to understand what they might experience. Having that understanding that these signs and symptoms here listed here can be expected, and if you're doing that slow taper, you're less likely to experience it. But I think if they have an expectation and an understanding that these might occur, it might stop that, I guess, the anxiety for the patient, but also starting their drugs again. So I just want to finish off on deprescribing. This is Philippe Pinel, who described deprescribing way back as an art of no little importance to administer drugs, medicines properly, but is an art of much greater and more difficult acquisition to know when to suspend or altogether to omit them. So I really don't underestimate the challenge to health professionals, and in particular to patients who want to get off benzos. But these are some sort of indicators: patients who are not getting the benefit or even increased symptoms, patients who also must take or need to take opioids, patients who wish to stop them. And I guess again, my biased population of patients, I see a lot of those in aged care. And patients who are at risk of falls, drug-drug interactions. Diazepam in particular has a lot of drug interactions, as does Alprazolam, and patients who are using it long-term. So how to deprescribe, and it is everyone has, if you're involved in this area, the way you do it. Probably years ago, the number one way of doing it was convert a patient to diazepam, because it has a long half-life and therefore less likely to experience these withdrawal symptoms. But the tendency these days is to do it either way, depending on the drug, depending on the patient, the duration, the dose, etc., the concomitant drugs, either switch to the equivalent of diazepam or just taper the existing drug or drugs they might be taking. So doing it slowly, they've been on it for a long time, they should be getting off it for a long time. So most people, unless they're on really high doses, were over 4 to 8 weeks, would be a suitable taper. I think if you do it much longer, this was a great article talking about this morbid focus. If it's over months and months and months, their preoccupation with it and those looking for the signals of withdrawal symptoms, it can have this sort of morbid focus with the patient. This is a really interesting systematic review that looked at the different ways, different approaches to benzo withdrawal. And the one that perhaps might surprise people was this switching to diazepam had a low level of evidence. So withdrawal, but whereas just that gradual withdrawal of the existing drug had a high level of evidence there. Tapering the doses, just an idea from the MPS Medicine Wise website, talking about the duration of taper linked to the duration of use. So if they've been on it for a year or more, a slower taper might be appropriate for the patient. But thinking about shared decision-making, patient-centred care, having that conversation with the patient around the risk, helping, and I get, albeit my patients typically aren't abusing the drug, explaining the risk, getting them to talk about, how do you feel in the morning? When do you have to go back and have a nap after morning tea sort of thing, helping them understand how many falls have you had in the last 6 months. And then the benefits, helping patients, which is, I find the most challenging, to realise that this tolerance has probably developed. And then arming them with the knowledge and considering their preferences, their expectations, their beliefs around the taper and what to expect, those withdrawal symptoms there. So that shared decision-making is a really important part of benzodiazepine withdrawal. And I won't read all of this out, but just really to highlight these tools. So this is the New South Wales TAG, Therapeutic Advisory Group, which unfortunately has just been defunded. But they've got some fantastic tools which you can use for discussion with patients and going through as well as for yourself, the steps in deprescribing. So this is talking about how to identify people. They've got this patient information leaflet here, and this is the Canadian deprescribing group, which is this patient leaflet to give to the patient, describing the taper and going through it. And this is the Canadian group's algorithm, but it's similar to the New South Wales TAG. I like this. This is what you can print out or fill in and give to the patient. Clearly adapt it. I think that's very useful. They give this general idea on how to wean gradually, reducing it by 25% of the daily dose every 1 to 4 weeks. And again, giving the patient these sort of non-drug, how to monitor it, and so forth. This preferred language is important there. This is how, if a patient discharges from hospital, this is their advice to use to give back to the primary care, to the general practitioner on advice how to taper the drugs there. These little diagrams I fill in for patients. They find them useful. Depending on their level of health literacy, I think shading it, that's diagrammatic, can be useful, and having that as an example for the patient can be useful. This was on the QScript. So that previous one was converting it to diazepam, but on the QScript education platform modules, they gave an example of a tapering plan for Alprazolam, and just going through it, and the patients can tick that off. So hopefully I've given you a bit of a snapshot of toward rational use of benzodiazepines. initiating it when it's appropriate, clinically appropriate, cautiously selecting when it is appropriate, carefully screening for these risk factors before initiating benzos. This concomitant use with opioids, I think, is such a red flag, and it is in fact a red flag on QScript. Regularly reevaluating, reassessing the patient, talking about these behavioural change models, having the non-drug support, the psychologists support, social workers support, pharmacists, especially doing home medicine review support is important. And I just wanted to finish off with this real prescription. As you can see up there, the date was just recent. Somebody sent it to me. Hopefully this is just an error in the prescribing, taking 25 stat PRN. But these sort of errors do occur. We all make errors. And I guess pharmacists are one of the stopgaps, the Swiss cheese model, having that role dispensing, picking up errors like this. And hopefully we can all work together as a healthcare team to support patients who are, whether it's using, misusing, abusing benzodiazepines. So thank you very much, and I'm happy to take any questions if there are any.
All right. Thank you, Debbie. That was very thorough and interesting. And I do have one of the questions here, and says, what is the first line treatment for alcohol withdrawal if it's not for benzo? So I know that you briefly touched on that, and my interpretation was that benzo shouldn't be the first line, shouldn't be the only treatment for the alcohol withdrawal management, but I'll leave that with you. Yeah.
Well, it's really not my area of experience or practice, but my understanding is diazepam is still, or clonazepam is still used because, as you know, the risk of seizures as well with alcohol withdrawal. So yeah, there's a range of, you guys probably know more about it than me, but there is a place for it, but it's a short-term place.
Yeah, absolutely. So I guess one of the questions from me is that obviously patients who are on, or clients who are on PRN, and then their benzodiazepine use is a lot harder to monitor in compared to someone who's on it regularly. So what's some of the advice that we should be given as clinicians when we see someone is on PRN diazepam or PRN benzos, and what are some of the things that we can provide for them?
Yeah. PRN use is problematic because if you ask a patient how many times in the last week have you taken these drugs, they might either underestimate it or not want to tell you, sort of thing. One of the things I do, whether you're talking about alcohol use or PRN use of psychotropic drugs, is to try to look at the quantities. So I say, especially with alcohol, I might say, how many drinks do you have in a week, typical week sort of thing? Oh, I only have 1 or 2 a night. How often do you go to the pub to get a slab, which is, got 24? And, that helps to, and you can do the same with medicines. If you have the dispensing history, I know many of these people will go to multiple pharmacies to have their drugs dispensed. And again, that's one of the real benefits of QScript, being able to see both from prescribing as well as dispensing, saying, look, you can see that they've had, and when I have pharmacy blogs, I ask people, are you already seeing the impact of real-time monitoring? And they're saying, people that have had 6 temazepam dispensed in 6 prescriptions dispensed in different pharmacies over the last week, sort of thing. So trying to quantify that actual use. If the patient genuinely, is in that phase of escalating and taking more, just helping them, and if they want to quantify it, asking them to use a diary, I think is very beneficial. And also trying to link it with how they feel at the time, or what's the precedent, the thing that stimulated their anxiety or not being able to sleep that night or whatever, So I guess there's multiple strategies depending on where the patient is, where they, with their abusing or misusing it, sort of thing.
So in terms of time frames, I guess, would you recommend, or if you're taking it daily, and I would, advise you to see a GP, or if they're taking every 2 to 3 days, is there a time frame that we can?
I typically, it clearly varies, but I typically say over the last 4 weeks, over the last month.
Yeah.
And you can see the dispensing. A lot of drugs on the PBS if they are taking it regularly, it's a month's supply. I know that's a generalisation and not always true, but typically over the last month, because if you say in the last a couple of days, clearly there's other things going on in their life that may precipitate it. So you're getting a better snapshot over a 4-week period.
Yeah, that's really good. Do we have more questions? One more, I think. So this question is about, should a long-term use of temazepam for sleep be given to all elder people at all?
It shouldn't. But reality is, and it is challenging in aged care. I have this discussion with GPs and geriatricians a fair bit. Aged care, perhaps end of life, are you going to put people through potential for withdrawal symptoms? And if they're on, I see people on 7.5 milligrams of oxazepam twice a day, 3 times a day, even just once at night to help them get to sleep. Is it psychological, almost a placebo effect? Probably. But are you going to, we've just got to be pragmatic and rational, I think. For people that are on big doses, I can remember one lady that was on 35 milligrams, 45, so a 15 and a 30 of Seropax, and she was taking it 4, 5, 6 times a day. And clearly, and she was, reduced cognitive impairment, inability to cope, day-to-day activities of day-to-day living. She was admitted to what was then called a hostel, a low-care facility, because she couldn't shop, she couldn't think, she couldn't, that executive function was lost. And, working with the GP, did a medication review and a slow tape of that person. And she went home, she was, was over about 6 months. And she actually was discharged from the hostel, which doesn't happen that much. So, and went back to work in a home. So it is a challenging question, especially as we go towards end of life. Do you? And the answer is in most cases, no. But certainly for people, not necessarily chronological age, but they're still functioning. Their risk of falls is certainly something that I look at, and in particular if they're on antidepressants as well, which increase the risk of falls. The multiple polypharmacy issues should be considered.